graduate health education. And my committee has Janelle Shepard and Dr. David Tesher. And so first of all, I want to welcome each of you and thank you for being here. And I want to kick off by saying that this is, I hope, a conversation and a dialogue. I mean, this is a stakeholders group, and we really are looking for absolute input. What we thought we would do this morning is have Stacy Silverman go ahead and give the presentation on a graduate medical education report from the coordinating board. And then after that, go ahead and have introductions so that we all know who's here and kind of what the institutions we're representing. But it really is a hope that this is a conversation and a dialogue where we're earnestly seeking your input and information on this. So with that having been said, Stacy, if you'll go ahead and kick us off with the presentation this morning.
Thank you, Chairman. Can you all hear me? Great. Again, thank you, and thank you for everyone for coming out on this rainy day. I'm going to walk us through the graduate medical education report that was required by the coordinating board to conduct under House Bill 2908. This report was actually adopted by the coordinating board in last April. And let me just go ahead and kind of scroll through the report. House Bill 2908 called for the assessment of graduate medical education opportunity. It directed the coordinating board to include this in its strategic plan. So every time we issue a new 5-year strategic plan, we will have this assessment in that from now on. So the assessment was looking at the adequacy of opportunities of graduates of medical schools in Texas to enter residency training. So our report presents conclusions and recommendations. And again, this was approved by the board in April. The report also includes 5 recommendations, which I'll go over. But specifically, the report required the coordinating board to compare the number of first-year graduate medical education positions available annually with the number of medical school graduates. So we wanted to look at, is there enough space available for those physicians graduating in the state to enter a Texas residency program. That doesn't mean they all have to enter a residency program in Texas. It just means that the number of positions should at least be equal to the number of graduates. We also included a statistical analysis of recent trends in and projections of the number of medical school graduates and first-year graduate medical education positions in Texas. And we developed methods and strategies for achieving the number of a ratio for the number of the first-year graduate medical education positions to the number of graduates of at least a 1.1 to 1, meaning more residency positions than graduates of medical schools. We also evaluated the current and projected physician workforce needs of the state by total number and specialty in the development of first-year graduate education positions, and examined whether the state should ensure that a first-year graduate medical education position is created for each new medical student position established by a medical school or dental unit. So Texas increased its medical school enrollments in 31% from fall 2002 to fall 2011. And as many of you in the audience know, this was in response to a national call by the Association of American Medical Colleges to increase the number of physicians educated and trained at our medical schools by 30%. And I'm pleased to report that Texas has, in fact, done that and actually exceeded that. So the fall 2011 classes that have increased medical school enrollments will begin to graduate students in 2015. So what's going to happen when those graduates come out of those schools? That's really what we're trying to work on here. The ratio of first-year entering residency positions to graduates in fall 2011 was close to 1-to-1. So about a similar number of medical school graduates were leaving our schools and entering residency training. That, unfortunately, won't be the case in the coming years. In 2011, Texas had more than 550 residency programs. 165 of those accepted first-year residency positions. At least 63 graduates of Texas medical schools will not have an opportunity to enter a Texas residency program if no action is taken. That is what we think is going to happen beginning in 2013. That's next spring, by the way. By 2016, at least 180 medical school graduates will have to leave the state for their first year of residency training due to a lack of residency positions. The state's investment in their education of $168,000 per graduate, or $30.2 million annually, will not benefit the state. The cost of adding additional first-year entering residency positions would reduce the loss of medical school graduates to other states. And while some of those graduates might leave and go do residency training in another state, some will stay there. Some will, in fact, come back to Texas. Resident physicians provide low-cost care to needy populations and tend to remain in the state in which they complete their residency training. This information is coming to us from the Texas Medical Association, their annual survey of what graduates' plans are. So thank you to Marcia Collins for sharing that with us. Residency programs are lengthy and expensive, with estimates of $150,000 to educate a resident physician for 1 year. Texas provides minimal funding support for residency training affiliated with health-related institutions through a formula allocation of about $4,400 per resident, or 3% of the estimated cost of residency education. An additional amount of $3,800 per resident is provided to the family medicine residents through a trustee fund that we've had at the coordinating board since 1989, something around that time. These funds, combined with the formula allocation, cover approximately 5% of the estimated cost of these residency programs. Funding support for residency programs is primarily through the Federal Centers for Medicare and Medicaid Services. However, the funding provided to each of the states is capped. So this slide shows the 10 most populous states and their percent over that direct graduate medical education cap for fiscal year 10. And this information comes to us from the AAMC. And it's not easy to get. The cap only supports a third of the cost of the 4,056 of the 4,598 actual positions in Texas, leaving the residency programs to cover the cost of the positions and the full cost of 542 positions. The numbers differ from the numbers you saw previously. Medicare, Medicaid, CMS does not cover pediatrics training, for example. So Medicare covers, in fact, the care for the elderly. Texas is currently over its Medicare cap by 13%, and the residency programs have to support the full cost of education of the 542 federally unfunded residency positions at an estimated cost of $81.3 million. Some of the cost is supported through increased patient care services provided by the residents. And again, that is providing care to a needed population in the state of Texas. Texas is attractive to physicians. We're a net importer of them. However, we're also attractive to lots of other people too. So the state's general population has kept the physician to 100,000 population ratio stagnant. If Texas were to reach the current national average of physicians per 100,000 population ratios for the 15 medical specialties that admit first-year residents, significant increases to the number of residents would be required beginning in 2014. If an additional 1,408 residents could be trained beginning in 2014, it would take the state 10 years to reach the current national average of physicians for just these specialties. If the state were to pick up the 10% cost of training these additional residents over the 10-year period, the state would need an additional $15.7 million beginning in 2014. And by 2017, the amount would increase to support 4,192 residents, bringing up the cost to an estimated $62.8 million annually. So let's go on to the recommendations that the report contains. The coordinating board's recommendations are that the state should mandate that at least one additional first-year residency position be added for each new medical student enrolled beginning in 2014. The Texas legislature should invest $11.7 million to support 10% of the cost for new first-year entering residency training positions beginning in the 2014-15 biennium. Health-related institutions and hospitals should prioritize establishing more first-year residency positions and maintain the positions through subsequent years of residency training that will be needed to accommodate the growing number of medical school graduates. The Texas congressional delegation should be encouraged to support congressional action to reconsider the current Medicare caps, which would allow the states with increased populations to receive support for expansion of residency training. And finally, the legislature should seek alternative funding sources, which may include industry, hospitals, and healthcare plans, to increase graduate medical education opportunities in Texas. On our report, just so that you all know, we'd like to make sure that you realize that we did have two consultants on the study. One is Atul Grover, who is from the Association of American Medical Colleges, and the other is Tim Henderson, who is an assistant professor at George Mason University and formerly with the National Governors Association. Additionally, we'd like to say thank you to all the other and recognize all the other organizations that we used to collect our information and served as resources. So that concludes my portion of the report, and I've provided my contact information in case anyone wishes to call me up and yell at me later. You're welcome to. And now I'm going to turn it over, unless you guys want to do questions now, or we want to hold off on questions,
Let's
get
do
through our...
each of these, and then we'll come back.
Lisa Mahler.
Introduce the people in the audience. I thought earlier.
We'll do...
You do that later?
Yeah.
Okay.
And Lisa Mahler runs our Physician Education Loan Repayment Program.
Good morning. Can you hear me? Is it on? Hello? Okay. I'm going to provide an overview that is really divided into three parts. First, I'm going to talk a little bit about some ancient history from the beginning of the program all the way up to May of 2009 when significant changes were introduced to the program, or legislation was introduced by the 81st Texas legislature. Then I'm going to talk about the changes that were implemented as a result of that legislation, followed by a discussion of the budget during the previous biennium and the budgetary changes in the current biennium and how we're managing that budget. Then I'll talk a little bit about retention. The Physician Education Loan Repayment Program was authorized in 1985 and was perhaps the only state-funded student loan repayment program in the country. We pulled together an ad hoc advisory committee representing a variety of stakeholders. And by the way, is Marcia Collins here? She was on that ad hoc advisory committee. I was on staff at the time as well. And this group developed a unique program model that was very different from the federal National Health Service Corps scholarship program, which had been in place for a while at the time. And that model is based on the idea that funds are disbursed after the service has been provided by the physician. Over the years, this has proven to be a very efficient model and, above all, has ensured that every dime of public funds has been spent for the purpose intended. Eligibility was based on employment by one of 4 state agencies named in the statute or practice in a federally designated health professional shortage area. Applications were conditionally approved at the beginning of the 12-month service period, contingent upon satisfaction of requirements and availability of funds. The award amount was not set in statute, but for the majority of the program history, the annual loan repayment award was $9,000. Funding was from a combination of general revenue and dedicated general revenue, which was 2% set-asides from medical school tuition. At the time, or for many years, it was only set-asides from resident tuition, but later out-of-state resident tuition was added. And the total funding over those years ranged from approximately $800,000 to $1 million per year. During this period, we were also authorized to carry forward and spend unspent tuition set-aside funds from prior biennia. Additionally, during the period 1989 through 2007, federal funds from a National Health Service Corps state loan repayment program grant allowed us to match state-funded loan repayments for qualifying physicians for a total of up to $18,000 per year. However, we stopped applying for these grant funds because the contract penalty requirements became too unreasonable and would have required a complete overhaul of the efficient model in favor of a model involving enforcement and collections. And I should note that many of our participating physicians qualified only for state funds during that period. Among your handouts is a table that shows the level of participation, funding, and expenditures over the years. The columns that have asterisks and there's a note there that says our financial reports, our agency's online financial reports don't include the years before 2001, and so we need to go back and research the legislation to fill in the blanks for the exact funding for those years. You'll notice that there was a significant drop-off in participation in fiscal 2004 as physicians completed 5 years of service and fewer new physicians were added to the program during the period 2004 through 2009. Based on feedback from various groups, we were convinced that this was largely attributable to the fact that the award amount was no longer competitive with other similar programs offered at the federal level and in other states, many of which, by the way, had modeled their programs after this program. So now I'd like to fast forward to the 81st session of the Texas Legislature in May of 2009. Passage of House Bill 2154 allowed for substantial expansion of the program, with the increased funding made possible through a change to the tax code for smokeless tobacco. To qualify, physicians must agree to provide 4 years of service in a health professional shortage area and must serve Medicaid and CHIP enrollees. Legislation, by the way, in the 82nd session, regular session, added physicians serving persons committed to a secure correctional facility operated by or under contract with the Texas Juvenile Justice Department and the Texas Department of Criminal Justice. And as I will mention later, since no new participants have joined the program since the spring of 2011, this change has not had any impact on the program. Physicians owing at least $160,000 or more qualify for $25,000, $35,000, $45,000, and $55,000 for the first through fourth years of service, respectively, while those owing less at the time of the first award qualify for the equivalent graduated amounts needed to repay their loans in full over a period of 4 years. Priority goes to renewal applicants, with first priority going to primary care physicians defined as practicing the following specialties: family medicine, family practice, general practice, OBGYN, general internal medicine, general pediatrics, medicine pediatrics, psychiatry, and geriatrics. And program rules do allow participation by other practice specialists if the Department of State Health Services determines that there is a critical need for the applicant's specialty in the health professional shortage area where the practice is located. There are additional priorities of application acceptance also outlined in the administrative rules for the program. And now I'd like to provide some background leading up to the current funding for the program. You may want to turn to that second handout, which includes excerpts from the General Appropriations Act for the 81st and 82nd regular sessions of the legislature. The fiscal note for House Bill 2154 was based on the idea that the coordinating board would enter into an interagency contract with the Department of State Health Services, whose role would be to promote the program to residents and other stakeholders, enroll eligible physicians into the program, verify service at the end of the service periods, and send the coordinating board an electronic file containing the data that we needed to verify loan information so that we could then disperse the funds directly to the lenders. The fiscal note includes only startup administrative costs for the first year, which was fiscal 2010, with first disbursements made in fiscal 2011 following completion of a year of service by the first cohort of new enrollees. However, as you'll see on that handout, you'll note that the appropriation for the first year included $7 million in dedicated general revenue from tax revenue, in addition to prior year and current year tuition set-asides. And although the fiscal note for the bill for 2011 estimated that $5.6 million was needed for loan repayment awards that year, the appropriation was $15 million in anticipated tax revenue in addition to the tuition set-asides and depository interest. So, as you know, just as the program was ramping up, the appropriation was cut from over $22 million for fiscal 10 and 11 to $5.6 million for fiscal 12 and 13. For this reason, the Department of State Health Services stopped accepting new applications, and the coordinating board's contract with that agency was not renewed. We have not accepted any new physicians into the program during the current biennium. And I'd like to acknowledge Connie Berry, who is, wave your hand, with the Primary Care Office of the Department of State Health Service, and note that even though the contract ended, her office continues to provide good support in terms of discussions about health professional shortage areas, and they also continue to well, if the program continues to be funded, continue to promote the program in their residency visits. The first cohort of new participants included 102 physicians enrolled in the program by the primary care office. The second cohort included only 43 physicians, and again, there would have been good opportunities to enroll additional physicians during the summer of 2011 if the budget had not been cut. Fortunately, our plan for managing the budget will allow us to fund awards for most of the four-year commitments without additional appropriations. We were able to encumber the unspent funds at the end of fiscal 2011 to allow for awards for second and third years of service completed by physicians by August 31st of 2013. Our plan is to encumber the $5.6 million appropriated for the current biennium for awards for all physicians from the second new cohort, completing a third year of service, and all physicians from the first cohort completing a fourth year of service. Our baseline appropriation request would cover the remaining awards for the second cohort. And McGregor is going to provide information on the exceptional item budget request for this program. Although the appropriation for the program was reduced, the statutory requirements for tuition set-asides and tax revenue allocations did not go away. If you refer to the funding handout, you'll see the total of $35.2 million was deposited in the PELRP account during fiscal 12. And there's a breakdown that shows how much of that is tuition set-asides, tobacco tax revenue, and depository interest. And at the bottom of that funding page, is a table showing that the state controller's original projections for tobacco tax revenue, the amount allocated to the program according to the budget consolidation bill that was passed during that same session, the 81st session, and the actual amount deposited in the account in fiscal 2011 and 12. As you can see, the comptroller's projections were right on target for fiscal 2011 and underestimated by about $5.5 million for fiscal 12. However, this provides insight into the level of revenue that we can expect to be deposited in the account in fiscal 13 and 14. Now I'd like to talk a little bit about retention. And in your handouts there is a copy of a report to the legislature, or to the LBB and the governor, containing data as of August 31st of 2012. Although the history for the ramped up, or the expanded program, I should say, is very short, the retention rates are really quite good. I can go to, I guess it's page 2. As you can see, there were 102 physicians in the first cohort, and only 6 of them had not fulfilled the program requirements by the end of the first year of service. So that's a 94% retention rate. And within that same group, 90 physicians have remained at their original practice sites or have moved to other Texas health professional shortage area sites. This represents an 88% retention rate for the second year of service for that first cohort. The second group, which was only 43 physicians, only 2 of them had not met their program requirements by the end of the first service period, June 1st, 2012. And as it shows here, a total of, I have a breakdown of the number of counties represented within each cohort, and then the total, the 2 groups combined served 70 distinct Texas counties, 47% of which are rural counties. There's also a little bit of information about the physicians who were already in the program at the time the bill was passed. They were allowed to continue to fulfill their maximum eligibility. There were 63 of them. We had anticipated that some participants would drop out of the program due to the reduction in funding, but it appears that our communication of the plan for encumbering the funds has provided reassurance that may have prevented some physicians from exiting the program. And finally, the map in your handouts, which was produced by Stacy's staff based on zip codes for current participants, reflects the location of the physician practices for those participants. And that concludes my overview. I'll be happy to answer any questions.
Lisa, are you tracking folks as they finish their obligation? Do they actually stay in those areas, or have we tracked them going back?
During the almost 30-year history of the program, we haven't continued to follow the people in the early days of the program. But beginning with House Bill 2154, we are going to continue to track them every year, regardless of whether they have have received their full 4 years of awards.
Good morning. And I wanted to just go through briefly and let you know what the exceptional item requests were from the coordinating board for the legislative session for funding for the biennium of 2014-15. We did request 2, one for the GME expansion program and one for the Physicians Education Loan Repayment Program. And as you can see, under the GME expansion program, and as Stacy talked about, we are going to request $11.5 million in new general revenue to support this program. This is to fund residency positions to increase us to get to the 1.1 to 1 level that we need to get to ensure that those 62 students or 180 students by 2014 and 15 and 16 are not lost out of state simply because we don't have sufficient residency positions. And so we would like to see the legislature fund this to try and give incentives to the residency programs to increase the number of first-year programs, as well as then to continue funding them in subsequent years. We are just trying to get to that 1.1 to 1 level that the coordinating board has determined to be the most effective to ensure that we have those positions available for our students as well as to attract new physicians into the state. On the physician loan repayment program, we have requested out of that set-aside funding, the designated funding, an additional $4.7 million, which would bring the total funding for the physician education loan repayment program to $10.3 million. This would allow for a total of 100 physicians in each of the new years in 14 and 15. Which would get us hopefully back to a little bit better level of funding and increase the number of physicians that would be able to be supported by this and the number of underserved areas that would be able to be reached through the program. And so those are the two special items that we're asking the legislature for in this area. And I think we're at the end of our presentations, Mr. Chairman. And so if there are questions or anything, we'll be happy to work on those.
Great. Well, thank you all for the presentation. Let's go ahead and do this, if you don't mind. Let's kind of, so that we all have a good understanding of who's represented. If you wouldn't mind, we'll kind of go around the room, starting with you, Mrs. Berry, as far as your name and who you're representing, and then we'll start the dialogue. And when each of you speak, there's the microphone, if you'll turn that on so that we can all hear you.
There. My name is Connie Berry, and I'm with Texas Department of State Health Services. And our office is the Texas Primary Care Office. So we measure shortage areas and assist with incentive programs to get physicians and other health professionals to those shortage areas.
Thank you.
My name is Ed Sherwood. I'm representing Texas A&M College of Medicine.
Sue Cox, UT Southwestern Medical Center here in Austin, regional programs.
Brad Marple, UT Southwestern Medical Center in Dallas.
Hi, Julie Brixey from UT Health Science Center, Houston, School of Biomedical Informatics.
Kim Pegg from Texas Tech School of Medicine in Lubbock.
Pat Stark from the University of Texas Health Science Center at Houston, and we have a grant from CMS to establish a model for graduate nursing education, and we're trying to learn from GME what we should do and what we shouldn't do to set up that program.
Lisa Nash, University of North Texas Health Science Center.
And Linda Andrews, Baylor College of Medicine in Houston.
Is that, I'm sorry, thank you.
My name is Claire Hawkins. I'm with the Texas Academy of Family Physicians.
Thank you. All right, thank you for that. And now I'd like to go ahead and start opening up for feedback and conversation about about the presentations that have taken place this morning. And with that.
Maybe I'll start. I have a question from the medical schools. If we are able to get funding, have you identified spots that could be new openings for GME, for first-year residencies within your regional areas? Have you had hospitals who would say, yes, we could afford to do this? And have they said, is the funding enough, or they will need more funding? Go ahead.
And piggyback on that also, there is certain flexibility with an ACGME to expand an existing program. If you could also tell us about your programs and how much you're able to expand, because the funding is going to come online certainly before a new program could be developed and approved by ACGME. So this is a short-term patch. But most of us, I think, would hope that it would be a long-term solution, but it's going to require also potentially some new programs. So what your program can do or is willing or funded to be able to do?
Again, I represent UT Southwestern in Austin. We assumed the sponsorship of the GME programs in Austin in 2009. At that time, we had 10 programs. We had roughly 189, 190 residents. We've added 3 programs. We've got 3 more programs in ACGME for consideration, and by 2015 we will have added 50 residency spots total. So,
is that per year?
It's 50 total, so the average length being 4 years. So it's up 12 positions a year. We'll be up to 16 positions a year when the new programs are approved. So overall, that'll be around 50 to 60 residents in the complement.
So with what the coordinating board is proposing, would that incentivize or enable you to expand beyond what your planned expansion already is?
Absolutely. It would be helpful. Right now, all of our resident spots in Austin are funded by Seton Healthcare Family.
May I ask a question?
Please.
Of those additional 50 positions, how many are first-year entering positions?
We'll have about 14, 15 a year.
Great, thank you.
I guess looking at being the other portion of UT Southwestern in Dallas, the Austin programs are in an evolutionary state and they're growing. There's great opportunity. In Dallas, when we look at the number of residents that we have in the entire program, and my numbers get a little bit muddy because now we include both the Austin programs as well as the Dallas programs. Currently, we have 391 slots that are dedicated to the 15 specialties that take PGY1 residents. As we look at areas to expand, obviously Austin is a wonderful opportunity. We also have relationships with several, sponsoring relationships with several family medicine programs around the state that perhaps have some opportunity for growth. One of the things that we kind of struggle with right now, in being a large program with capped numbers of federally funded or CMS funded positions, we well exceed that 13% that's reflected in the state in terms of national funding. So the 28% cut in the state funding for our existing positions has really hit us hard. So while the additional funding will help us, it also kind of is offset a little bit by the decreases that we've taken up to this point. So that's one of our, I guess, our real world, I don't really mean to bring that up as a complaint, but kind of a real world struggle, and we're also looking at potentially 10% decreases in federal funding as well. So for larger programs that have established residencies and will not be able to establish new residency programs within our footprint, that will be kind of a struggle that we'll have to deal with.
So as you're dealing with that, is there any conversation about decreasing the size of your existing programs?
That's one of the things that, and this is a discussion that has to be taken place, that has to take place on a little bit more microscopic level. So there may be a discussion that circulates or that's focused on internal medicine, just to pick a specialty. We take around 60 residents, PGY1 residents a year. I think it's 57 this last year in internal medicine. There's another side to this discussion, which is the availability of patient experiences to be able to train those. And at some point, you can imagine if we grew, we'd love to grow another 60, but we might have 60 residents that aren't trained very well. So on the other side, we do have to continually adjust. Have we gotten too large in some of the areas? As we've looked on our campus, the areas where we may have expanded beyond our resources and we may want to tailor, kind of trim those back a little bit, tend to be more focused in the fellowship areas, the postgraduate years that would be PGY4 on. So I think that's not necessarily admissible with the intent of these additional PGY1 spots. But yes, it's something that we do need to we do look at on a regular basis or continually.
Yeah, and I think you're hitting on a point. In internal medicine training, many of those individuals don't go into primary care, general internal medicine, but go on into fellowships. And so, we're working against building a base of primary care trained ACP board certified folks who could do general internal medicine, i.e. primary care, medical home, as a pathway to solving the needs of the future medical home. And so it may behoove us to look at, do we need all of these additional fellowship-trained folks, or is there a conduit or an incentive program to say, your 3 years of general internal medicine training is really all we need to train you in. Now we need you to go out in the workforce and be a primary care internist.
I couldn't agree more. There is an incredible drive for many of, and it's true in pediatrics as well, to look for postgraduate training. With that being said, many of those individuals or a certain percentage, and I don't have a number, will focus on general internal medicine training with a sub-focus in, say, endocrinology or something. But it's hard to know exactly, at least in our program, how many will do that eventually.
So you're using a sponsorship model with your Austin campus or your Austin groupings. Are there other geographic areas where a sponsorship model might work?
For our programs,
thinking of like East Texas or something.
Yeah, it's a model that works, and I think that certainly could be explored. We've not explored that beyond our Seton relationship.
Are any of the other institutions looking at that model in your business plans?
Oh, go ahead.
From the ACGME standpoint, I think the challenge would be to make sure that we can prove to them that we would have adequate oversight, and I think that's the biggest issue in doing things very far away. In Houston, Conroe or Beaumont or places like that are within a reach. You can make sense that a faculty member could get there and do things, but much farther than that, and I think you really have to work hard to assure the ACGME that we're doing the oversight that we need to. But there are models. Mayo does it from Minnesota, Florida, and Arizona under a single sponsor in Minnesota. So it's not that they don't let that happen.
So is your health science center looking at that model, or is it just you're thinking that might be something that would work?
So several of our institutes, so the VA in particular is very interested in having our trainees be able to go farther out of the city than just core Houston. The county system is spreading, but not much beyond that. So a few specialized areas maybe, but not really.
For Texas Tech, we are expanding a little bit out into the rural communities that are in close proximity. For example, our family medicine residency program, we now have 2 residents that are doing PGY 2 and 3 in Plainview, a small town about an hour north of Lubbock, and that has just been started. And they're within a reasonable driving distance, and actually some of the groups, this is a good thing, some of the groups that the residents are working with are actually graduates of our residency programs, and so that they're familiar with the educational process and working with them. And so we also have extended our reach within the Lubbock community to some of the private community hospitals who are stepping up a little bit more to provide funding for residency and some fellowship positions as well. And more so in the internal medicine subspecialties, as far as some of the local hospitals there to provide coverage. And I think that from the Lubbock standpoint, we do have opportunity to expand both in-house our GME numbers a little bit, but definitely within a close enough range in the rural area surrounding that we could take a look at that.
For University of North Texas, we have about 200 residents that are in programs affiliated with our institution, scattered all over the state. Most of those are family medicine programs. We do have 2 internal medicine programs as well, and a number of fellowships that are generally pretty small. Most of the interest from our existing partners in expansion over the last few years has really been in the area of the internal medicine subs. Generally, they parallel revenue lines that their hospital is interested in, or additional growth that the hospital would like in terms of who they would attract or retain to stay in their area and on their staff. But we do have, with one of our hospital partners in Fort Worth, potential to double the size of our existing family medicine program. We've been moving slowly in that direction, have just acquired a new continuity clinic site that would facilitate that expansion. But honestly, moving cautiously forward because we are well over our cap, as everybody else is, and so the hospital is looking at needing to fund all of those additional positions essentially out of the hospital budget. So that's definitely been a handicap that has slowed our desire to grow that program. We have had a small increase in that same hospital's internal medicine program through expansion with the VA. We applied for some FTE slots through the VA and have partnered with them to fund that growth, placing some of our residents in rotations in the VA facility, and just had a meeting with representatives from the VA that program has gone so well, they're interested in further expansion, and so we're looking forward to probably adding 2 more entry-level positions through expansion of that partnership in the 2013-2014 timeframe. Other growth, we have been approached by one additional hospital in the last few months that's looking at either a family medicine program that would be new in a GME Virgin hospital, so they don't have a cap, and that they're interested in either a family medicine program or a combined family medicine emergency medicine program, and those negotiations are ongoing. We also have one of our existing partners that is interested in perhaps a new psychiatry program, and so those would be entry-level positions. Based on the needs and interests of our graduates from TCOM, what we really need is an additional pediatrics program and an additional OB-GYN program. We've not been able to identify a hospital that's interested in that growth.
Did you use a term, a GME Virgin?
I did.
Okay, can you explain what you meant by that?
They have no cap. They've never had graduate medical education in their facility. It's a community hospital that's large enough to accommodate at least a family medicine program. They could probably also do internal medicine, but their interest at this point is family, so that's what we're moving forward with. So
they're largely self-funded?
They have no GME at this point, so they will be eligible to apply for new positions.
I see. Okay. Are your programs accredited by ACGME, or is there an alternate accreditation body?
We actually have both. We have some programs that are accredited only by the AOA, which is the other accrediting agency, and then we have some programs that are ACGME only, and then the majority of our programs actually are accredited by both.
And the ACGME process for a new program takes several years. Is the AOA process similar?
No, it is much shorter. We can generally get a new program application through, the facility inspected, and the program started within about 18 months.
Good information.
Go ahead. If I could answer your question, I represent different areas. I'm a family physician who operates a residency program in Baytown, Texas. I am on the GME committee with the Methodist Hospital because that's our GME group, with about 200 residency positions at the main Methodist and 25 at our facility. What we've found is that as I've sought out other partners to expand these residency programs or make disparate proposals for residency expansion, there is certainly capacity in different places, but no one's interested in funding it themselves. So with secure funding, I do believe there is capacity to grow. I've explored with Baylor College of Medicine, where I have my faculty appointment, and they have reduced their family medicine residency positions over several years and could restore those. So in direct answer to your question, I have several places that would be willing and ready to scale up if there was secure funding.
What do you mean by secure funding? Because one of the concerns we've had as a coordinating board, if we ask for an LAR request this year, biennium, is it going to be permanent funding? You don't go build a program just for 2 years and then have the funding going away. Is that what you mean by that?
Well, exactly. I don't know what it would take to get the institutions that I'm involved with to believe that the funding is secure in healthcare reform, in state funding, in private funding, and so people are skittish, and that's why efforts to create district proposals for GME expansion are foundering.
So how could we ask that the program be designed such that folks felt there was security to that funding for not a biennium, but maybe for a decade or more? In other words, how do you design that to keep the people that are going to put the program in place to feel that security?
10 years sounds good, but I believe 5 years would probably convince people that people were serious.
Okay. Anybody else have a different?
I was going to say, in a
alternate?
related way, when we make arrangements with hospitals, we try to write language that says at least through the length of the training of the physicians that enter the program. So if it's a program that's 4 years long, the commitment at least has to be to let the ones who begin finish. And that's my only, I'm so appreciative of all these efforts to try to do more, but to do just first-year positions, I think is scary to make that commitment because the programs are 3 to 6 years at length, kind of on average.
In Texas A&M, over the past 2 years, at the behest of our president and dean, both of whom have had a very strong commitment to the expansion of GME with special emphasis on primary care disciplines, we've talked to people all over Texas, except West Texas. We haven't been invading Texas Tech's territory yet. We've talked to big systems. We're affiliated with Baylor and Dallas and Scott and White up the street in Temple. We've talked to big systems that are GME virgins. We've been out in rural areas where communities think they'd like to start a family medicine residency. And the common theme is that when the communities that haven't been involved in GME are shocked at how long and how much money it takes. The ones that are more sophisticated, that are already in the business or are big systems and have friends that are in the business, are mainly put off by the uncertainty of the future funding. And the greatest uncertainty comes from Washington with threats to the CMS funding. They're just afraid to make major investments when they don't know where the money's going to come from in the future. And an investment like this is something they can't turn around on. They really get egg on their face if they say, well, this new program we started we can no longer afford, so 3 years later they're going to shut it down. So getting them to bite, I agree with the statement. There's capacity out there. There are places in Texas that could provide GME training and would benefit the quality of care in those communities by getting everybody into the medical education state of mind. But they're afraid to move because of the uncertainty of future financial support.
So we've proposed a 1.1 to 1 ratio. Obviously, California has a completely different model. They import a lot of MDs, train them, and then they put practice up in California. Should we continue to look at the lines of a 1.1 to 1? Or do you have a recommendation for a different ratio?
1.1 to 1's a lot better than where we are.
Yeah, well, we're under 1 to 1 this year.
Mm-hmm. I would think that at least is reassuring to the students, the applicants to the medical schools, that that capacity exists and they could complete their medical school education and their residency training in Texas. That is a pitch you can make and a legitimate thing that the students can get their head around and understand. So I think it's a important goal.
When we track kind of the fate of the residents that finish our program, we find that, and we can only track, once they get out, it's kind of hard to track them for a long period of time, but for the first 1 or 2 years, we can track where they go. And we found that about 54% of the residents that finish all training programs, the subspecialties as well as as our core specialties, About 54% will stay in the North Texas region, and just over 70%, around 72%, stay within the state of Texas. And the reason I mention that, it appears, and I think there are other data that suggests this, that the likelihood of people staying where they last trained is pretty great. So in the discussion of what is the appropriate ratio of residency spots to finishing our graduating medical students, if there is a goal to more rapidly increase the influx of physicians into the state, entertaining an increase in that ratio might be worth some discussion or investigation.
To come into Texas.
To come into
Texas.
Texas.
Accommodate both the students and the folks.
So we'd be able to actually pull some of those California grads.
So a ratio of
PGY1 residency availability to our graduating residents, our graduating medical students.
So at what level would you think?
That I don't know, because I think that's determined by where you want to target that per capita rate of physician coverage. Also, it might address some of the distribution issues if, in fact, if that ratio were not just focused in major metropolitan areas, but also was somehow or another distributed across the state in underserved areas. It might be a way to bring in some trainees from Arkansas and Oklahoma and other parts of the United States. And once again, our data, like other tracking data, suggests that people tend to stay where they last trained. They form relationships, and it's a long period of time that you really get involved in the community.
Gregor?
Just real quick. To be clear, is there anyone that thinks it should be lower than 1.1 to 1?
Oh, no.
Thank you. I just wanted to make sure we were clear on at least consensus that we were at least cool on that.
So I was thinking 2 to 1. We've already had that conversation.
Right. No, and I appreciate that, and I think, incremental improvement may be, it was what we were trying to do with the study, was to at least have something that may be realistic, and especially in a tight economy, maybe trying to shoot for 1.1 to 1 and 10% of the funding, while not ideal, may be something that was attainable. And so that was kind of what our goal was to find something that was reasonable and hopefully attainable.
I just one other comment about that. I mean, I would certainly be excited about 1.1 to 1 or more. There are several states that their model is to import medical school graduates from other countries, and family medicine specifically nationally and in Texas has had difficulty attracting U.S. graduates because of payment rates, profile in medical schools, and other things. So there is a lot of availability of Caribbean and international graduates to occupy GME positions if they were available. Having said that, as a residency director, we place value on U.S. graduates for selection.
How do your offshore graduates perform in your program? Are they able to compete at the level of the U.S. graduate or the Texas graduate?
There's 2 ways of answering that question. One is on standardized exams. So for the American Board of Family Medicine exams, they perform slightly lower, not substantially. In terms of performance in patient care, it's just a wider standard deviation of performance. There are some excellent ones and some more difficult ones. So that's why most residency directors would prefer, if possible, to have U.S. medical graduates, because there's less variability in the product.
Do you factor in a Texas graduate as a preference for entry into your residency?
Virtually all of the family medicine residencies that I'm familiar with do, yes.
I was just going to make a point about, from the perspective of admissions to the medical schools, that this information for these applicants, knowing what the ratio is for residency positions for the number of students graduating, is going to impact our admissions. And from the perspective that we may stand to lose some of our most competitive students to other states from the get-go, if they are concerned that there's not opportunity within the state of Texas.
So they would choose an out-of-state medical school because of the lack of perceived lack of GME opportunity?
Yes.
So they're aware of that and thinking about that at
yes.
that point?
Yes, very much so.
Do we have information as to what the ratio is in other states from a comparison standpoint? I mean, are there other states that are going to be actively saying we've got plenty of capacity from a GME standpoint, so we're recruiting you?
Well, there's certain states that, and you go back to the CMS funding formulas, certain states really got into the GME business.
Right.
California, New York, probably in reverse order, were huge importers. They've retained that funding even though they haven't grown population like Texas has. So here we have, there's rapid growth, rapid need, and we're on a model of 20 years ago funding, and it's not keeping up with us. That's why, you saw in our report we talked about this. It's so important for us to have a federal solution to this. We need them to unlock and recompute that formula so that it's fair to the more populous and growing states to be able to train in their own population graduate medical education. But the funding formula is locked, and without a federal solution, it makes a lot of the surety issue even more acute on chronic.
I think a picture I've seen, Texas is among the states that would most benefit from recalibration of that number because of the things that you're just talking. It might be at the top, actually, of the list that would benefit if they would redistribute.
I want to emphasize the ratio being greater than 1.1, or at least 1.1 to 1, because we did a survey of our students that finished a few years ago, and I need to follow up on this now that they've all finished their training programs. But of the majority of students at Southwestern, roughly 25% stay at UT Southwestern to do their residency. Another 30 or 40% go to other places within the state of Texas, and maybe 30 to 40% leave the state. We asked those kids, did you want to stay in Texas? And of those that left, they ranked more Texas programs, several above where they ended up matching, because there was not a spot in Texas for them to match into. What I need to do now is take that cohort and see how many came back to the state.
Yeah, that would be the question as to, of those 30 to 40% that left, did any of them, what percentage of them came back?
Well, 100% that said they wanted to stay in the state said they would come back to practice. So now we go back and say, okay, where are you practicing?
Stacey, we have those numbers. I think the TMA has published those. I'm looking up over at Marcia. Of the folks who are Texans, trained in Texas, do GME outside the state, how many come back? And basically, it declines if you do both medical school and residency here. I think it's somewhere close to 80% are retained, and then it slowly goes down, the preference being medical school somewhere else, GME here, and then medical school here, GME elsewhere. And Marcia, can you?
We are challenged just as everyone else is in being able to identify the percentage that actually do come back. If they leave the state for residency training, how many of them eventually do come back? We do very well when you look at the Association of American Medical Colleges data, when they took a point in time and said of the physicians and where they're practicing at this time, how many of them completed medical school in that state and how many of them completed graduate medical education in that state. And Texas actually ranks very high in terms of those retention rates. But we have a very difficult time because of the numbers and because you're talking about physicians that have migrated all across the country and being able to track them where they are. We have a good sense of being able to look at licensing data and how many of our own physicians completed one level of training here. But those we've lost to the other state, those are the ones that are very difficult for us to track.
Is it possible to work with the Federation of State Medical Boards and say, here's a list of Texas graduates in the last 5 years. We know where they did their residency. Where are they now?
Where are they?
We actually had asked the American Medical Association, and Dr. Tischer, you may recall this, we had a resolution going before them asking for the AMA master file for this type of tracking, and we had a major pushback in saying that the expense would be extraordinary. The fiscal note they put on that was several $100,000, just saying the tracking of the numbers was significant. Perhaps finite number of saying we were thinking of looking maybe at 7 or 8 years ago, and maybe they've completed now, full residency track and seeing ultimately where they entered practice. So that is something that we're very interested in doing. We've not done that as yet.
I wanted to follow up on the comment that there was a need to change the CMS formula and the cap to redistribute slots. I think we need to be more ambitious than that. The current model funds GME through hospitals, and patient care has largely moved out of hospitals. The disciplines we need most, the primary care disciplines, do less and less of their training in hospitals. So we need an entirely new model, perhaps an all-payer system where private insurance funds GME as well as Medicare, something that includes pediatrics, perhaps that provides funding through FQHCs. But we need the model we have now is not going to serve us in the future.
So you saw our recommendations on the 2908 study. The last recommendation really kind of hits on that, a, quote, all of the above approach. Do you have any specific things that we could recommend to this legislature of how to get other alternative sources of funding in order to fund specifically GME? In other words, not necessarily look to the traditional one, which is CMS and the state, but where do we get other revenue in order to fund GME? And that's a rhetorical question because I don't have the answer either, but we wrote it up as our last recommendation, alternative funding sources, right, which may include industry, hospitals, and healthcare plans. Any ideas on that?
Two of the most successful family medicine community-based residency programs in Texas are located in federally qualified health centers. And so if a new scheme was to favor certain models that were not hospital-based, that would be a direction to go.
Is there funding available for additional federally qualified health care centers?
I don't know the answer to that.
I can't cite the specifics, but there has been some federal funding for GME slots through FQHCs. And I want to second that suggestion because the FQHCs are taking care of an awful lot of the patients that trained our generation, except they were in inner city hospitals, perhaps uninsured. And you need patients as well as money to train doctors, and that's where the patients have gone. So that is one good idea. The second thought I'd offer is the state funding for GME, if given the relatively small amounts of money available, if we divide them up on a capitation basis as we've done in the past, they'll have very little impact. It would be better to lump the money and do something truly innovative that will make a difference in one arena and maybe, with success, set an example that could be replicated for other disciplines or other areas.
So how would that work? I think I understand what you're saying, but you're talking about start an FQHC and lump the money in that and use it primarily as a driver for GME for patients that don't otherwise have a medical home?
I don't think that I have the answer on how to tie it to FQHCs. We work with two different FQHCs, and if there were external incentives that made it in both parties' interest to work together, if there was funding that was contingent upon a College of Medicine and an FQHC developing a stronger partnership, that would facilitate stronger partnerships. Another way that money could be concentrated would be to recognize one of our biggest needs. Now, I'm going to throw out what I think is a big need, and I may get a lot of argument around the table, but I think we need family physicians in rural communities in Texas. So if our money were used to work with communities that want to start a family medicine residency and to give them extraordinary subsidies to get them going, maybe we could have some success there. When we talk to big healthcare system executives, they're much less interested in family medicine than they are cardiology or orthopedic residents because those programs contribute to the hospital's bottom line a lot more than family medicine.
Yeah.
I might even, go ahead. Go ahead.
There is funding in the Affordable Care Act to expand FQHCs. It was a $1.8 billion sort of trust account that was set up specifically to expand FQHCs. And in addition to that, there was funding for FQHC residency programs. So there is a lot of interest at the federal level and through the Affordable Care Act to make that connection between residency training and FQHCs. We had an FQHC incubator program in Texas that was funded to develop new FQHCs and expand existing FQHCs. And that model might, be a possible way to look at expanding FQHCs further into residency programs.
I was just going to add, in addition to thinking of the specific sites, I think, as someone else said, a disproportionate amount of the primary care training must occur in an outpatient setting. So internal medicine, pediatrics, family medicine, psychiatry, and so other ways of thinking creatively about spending the money, that training experience is essentially unfunded no matter the discipline, and it really hits hardest on the primary care specialties. So just another way to think about maybe not a site tie, but a clinical experience training tie to the outpatient experience might be the other. The other thing I was thinking is we haven't really mentioned, but it seems to me from what you presented that the loan repayment program is another potentially really effective way, because it targets that group of physicians primarily taking care of patients in general specialties. And another way of marketing Texas that even the students pay attention to at the entry level to admission to medical school, that seemed to me, as listening through everything, to be something that was very effective for the money that was spent.
So there's been, a lot of talk, and I don't disagree about the need for family medicine, primary care. But if you look at our state statistics on a per capita basis of the 40 major specialties, we're only at the national average on 3 of them, and we have significant numbers of specialties, including orthopedics, that are below 80% of the national average. So would you say we should concentrate the small amount of resources that we're going to try to devote to this exclusively to primary care, or should it be whoever wants to expand something below a certain national average? Because the challenge that staff and we have had, and we've probably reached out to a number of you, is there's no normative scientific data that says this is the ideal ratio of this type of a physician compared to 100,000 population. And so that would be, I guess that's another new question. Everybody can kind of jump up there and try to answer it. It's about 3 questions in one, which is, should we exclusively concentrate on primary medicine? And you're right about psychiatry and child and adolescent psychiatry especially. We're way, way low on that. Or should we just have it go to whoever is willing to start new programs or add new slots within that? And then does anybody have any data that indicates what the ideal ratio is, scientifically proven, of the population for any of the specialties?
I don't think anybody can have that data, because we're talking about training doctors for our current healthcare system, and virtually every doctor I talk to thinks our current healthcare system is broken and unsustainable, and we need a new healthcare system. It needs radical reengineering, so we should be targeting the kinds of workforce, kinds of physicians we produce for a vision of a better healthcare system in the future. Now, just a 30,000-foot view of what's not broken and what is broken. People come here from all over the world for tertiary and quaternary care. They're voting with their feet, so we must be doing that pretty well. That's where an awful lot of the money's being spent, and much of that money's being spent on stuff that could have been prevented by better primary care. So it seems to me that if we're going to target money anywhere, we ought to look to a future healthcare system that has a much more robust primary care infrastructure that prevents people from needing the expensive things that we're able to do for them today in tertiary settings.
So I guess your answer is yes. We should target primary care.
Yes.
Yes.
And I don't disagree. I think we have to have a different model, but, everyone sitting here probably has a vision of what they think that model would be, but at the very least, it's going to have a primary care medical home for every human being. And we're not anywhere close to that.
I would take it a step further than targeting primary care. I would target the creation of family medicine residency. I keep saying family medicine because my discipline, internal medicine, has abdicated primary care. And pediatrics, under the current rules, it's hard to set up a program if you don't have a pediatric hospital. So I keep coming back to family medicine. We should target the creation of programs only in places that have certified patient-centered medical homes where they teach in a team environment where the physician's efforts are extended, because the harsh reality is we can't produce enough primary care doctors to take good care of our nation. We can't do it. They're going to have to start working in teams and leveraging their expertise through various types of extenders. So we might as well reward that model.
So I have a question that you mentioned. You've submitted district applications to try and address some of this. Is that what you're saying?
I was. Our health system was trying to get collaborators with others to try and put forward proposals, and we didn't get it past the first stage of development because people weren't interested in putting the money up front for it.
But you think that those funds could be used for that if you had partners who would, and of course district funding is kind of a...
Our hospital, it's still pretty difficult to know where that's going, but our hospital is interested maybe in looking at round 2 funding in a couple of weeks, but round funding we said no. I wanted to support what was just said earlier, but I also wanted to go back to the actual question, which was, should we take a market approach and see whether GME systems currently want to expand their GME programs? And the problem with that is that it's based on the current artifact that was mentioned, which is, do your 4th and 5th and 6th-year residency positions bring cash into your hospital system? So they will develop programs that have revenue associated with it. And family medicine residencies typically are cost centers, not revenue centers.
I agree with that. I think we're never going to have enough money to do what we would really like to do if in a perfect world. And so the comment was made earlier about concentrating the available funds or the requests for new funds in some priority areas so that we can demonstrate some success. And I would have to agree with that. I agree with Claire completely. The hospitals are going to continue to fund expansions for interventional cardiology and orthopedic surgery and all of the fellowships that bring money into the facility. I think our best bang for the buck is going to be in those entry-level positions, family medicine, internal medicine, psychiatry, pediatrics, and so on.
One other aspect that Texas Tech is involved in right now, we have our first cohort of residents in our family medicine accelerated track who will be graduating in 2013. And there are other institutions within the nation who are moving towards an accelerated program specifically for family medicine for all of the reasons that have been discussed here. And so essentially that's going to give a bump up of graduates earlier that and as more and more schools develop and they're looking at this in general surgery as well, OB-GYN, some of the other specialties. And so that is something else to take into consideration as we're not only admitting more students to our classes, but have taken a portion of those students and having them complete in 3 years. So
I'm sorry, so it would be a 3-year accelerated to 3 years.
We do, and it's only...
You're currently doing that?
We do. Our first group will graduate medical school in year 3 this coming May, and they will enter a family medicine residency program, which will be the traditional 3-year program. And they don't lose any curricular components. It's rearranged. They go to school during the summer, and, it's all... LCME is pleased with it. But we do know from the multiple other schools that have come and looked at what we're doing and what we've had approved that there are many schools moving this direction. And so we could have more of an influx of people needing first-year GME spots as a result of that over the coming literally 2 to 3 years.
What are your numbers entering that program this year?
We are accredited for 12 spots. And so this first cohort, I believe, is going to come out with 9. That will be graduating and going on into the residency position. And we are up before LCME for a relook in 2013 and to see about if we might expand that a little bit further. The interest has been overwhelming, I must say.
There's a model in place now with UT System where academic medical centers have partnered with the undergraduate campuses to have a 6-year to 7-year high school graduation to med school graduation, and the entering groups are right now starting this year, so we are going to be increasing the number of medical school graduates.
We have programs along those lines as well, where they complete their undergraduate. They could complete their undergrad in 3 years, their medical school in 3 years, and so a total of 6 instead of 8 for that. So for a select group of students, mind you.
Right, very few, but right. I think it's a great project. Are the students paying a little bit less for their medical education, and are they coming out with a little less debt?
They are, because their second year is scholarshiped for their tuition and fees, and that has come primarily from some funding within our institution at this initial startup. And the students that end up on our Permian Basin campus, on our Odessa Midland campus for family medicine residency, that is our newest regional campus. And so there are some scholarships that come with year 3 at that campus. So technically, some of those students come out paying for 1 year of medical school tuition and fees that go to that campus. But the rest of them in the FMAT program pay 50%. Of what their total educational costs would be, and about 75% of their living expenses. And then they're in a income generating state a year earlier. And so those are the pros from our perspective. So
do the entering students, the entering medical students, have to commit to being on a family medicine training program?
The last 2 years we have accepted students into this program with the general admissions cycle. The first year we selected students that showed interest in it from our first year medical school class, and we still keep some seats open for those students who have a revelation during their first year that they really want to do family medicine. But we talk to them and try and vet them out. We've not had a lot of attrition due to changing their minds as far as specialty. We've had some people move, get married, those kind of things, but we really haven't had students say, wow, I just decided I don't want to do family medicine.
So I remember when my medical school class made up its mind about its residency, and it was sometime during the 3rd year. Are these students different? Do they make their mind up before they enter?
Well, I can tell you.
I knew before I went to medical school what I wanted to train in.
What you wanted to train in.
Yeah.
We do, at our institution, with incoming orientation, the students fill out a little paperwork and goes in a time capsule, and about 70% of our graduates stay true to what they thought they would probably end up doing 70%. When they came in. Mm-hmm. About 70% of them do. Now, in the FMAT program, we do have, as you might expect, a significant number that are non-traditional students who maybe are coming from a previous career, and they're very interested in shortening the time in their educational process and from an expense standpoint. And so some of them are well prepared to commit to what they want to do at that time.
What fields are they coming from? Nursing, physician assistants?
Some from nursing, engineering, law, quite a variety. School teachers.
Okay.
So help me here when you talked about and enumerated quite a few pros. So what are the specific cons to that thought process?
Well, as we've worked through this with this first cohort, there's been some adjustment as to whether the accelerated curriculum was going to be too heavy a burden for the students. And at least for this first group and the second group who are now in their second year, they are finding it doable. There have been transitions that occurred a little earlier than they do in the normal 4-year curriculum. So our second-year students do a longitudinal family medicine clerkship during their second year. And so some of the transitions that they go into when they start doing some of their clinical care in the hospital hits a little bit earlier. And I think we were just not quite as prepared for helping be so supportive of them in that change. But they have all passed their step 1 with reasonable scores. That was another milestone that we really needed to see if that was going to somehow decrease their performance on their standardized exams. And their NBME shelf exams, they're performing along with their 4-year cohort. So there's not, we haven't seen any really a big downside yet.
So is there any disruption with 3-year and 4-year tracks running parallel within the medical school?
Well, the first year is the same for everyone, and then they depart onto the 3-year curriculum after first year. They do a summer segment. They do most of the second-year curriculum except for the clinical aspects that are put in there, because they're actually in the clinic twice a week in their family medicine clerkship. And then that 8-week period of time that would have been dedicated during their 3rd year family medicine clerkship then is utilized to put in some of their sub-I, some of the things that they would do in their 4th year. And so there's a little bit of the traditional second-year curriculum that they are excused from because they are already in the clinics, more than our 4-year students are in the clinics during second year. But they handle the rest of the didactic curriculum very well.
In your traditional second year, is there clinical experience in that traditional second year?
Yes. It starts from the first year through the second year. We have clinical experiences that include actually seeing patients. In their first year, they're learning their physical exam skills and their history taking skills with patients either in the clinics or in the hospital under the supervision of a faculty member. And so they're in the clinic a half day a month, and then there are small group sessions that they work with and do professionalism, ethics, hot topic kind of things, and just various aspects of acculturating to the field of medicine.
So when I was interviewing, there was only one school that had a 3-year track in the state, and that was Baylor. And they had the most miserable medical students around. I mean, they were just miserable because it just was a heavy load.
Yeah, clarify that.
I wasn't miserable.
I'm sorry?
I went to Baylor in the 3-year.
Did you do the 3-year program?
Of my class, entering class of 168, though only 12 of us graduated in 3 years. Everybody else did the 4-year curriculum.
Okay. But, so, I mean, this is getting to some of the things that we as a coordinating board would like to see: reduced student debt, throughput, you're eliminating redundancy in training, and, you're getting from point A to point B in a quicker fashion. It'll be interesting to see how this rolls out. I wouldn't be surprised if your entire student population wouldn't want a fast track like that anyway.
There is a little bit of envy. I want to do that. Yes. Definitely.
But again, you're only allowing those going on to family medicine.
Right now, it's family medicine, and the reason is that family medicine is who does primary care.
Right.
And so that was the initial choice for this. I will say that our clinical surgery department is highly motivated to look at doing this with a general surgery track as well.
What about psychiatry?
I can't. I'll let her.
No, at Baylor, we still have 18 months for the basic sciences, and so we are trying to figure out creative things to do with the PGY4. And psychiatry is one of the programs that would love to try to cut that year short. They're also trying to do that in the 4th year of the psychiatry residency program to make that into a fellowship year rather than doing 4 years and then fellowship. So that discipline in particular at Baylor is eyeing the 4th year of medical school because our students are already finishing the basic sciences after 18 months. So it seems like a logical thing for us to do.
Right.
Is the American Board of Psychiatry require a 4-year GME experience?
So it requires a 4-year GME, but if you do child and adolescent, you can count the 4th year of general as the 1st year of child, so you can make 6 years into 5 already. And so the other fellowships like geriatrics are thinking, couldn't we just do geriatric psychiatry in the 4th year the same way that you let child psychiatry count the 1st year of child as the 4th year of general?
And is the American Board of Medical Specialties involved in this, deeming its certifying boards?
They are looking very closely at, because most of the psychiatry fellowships are only 1 year. So the idea that 5 years could be made to 4 and get people out, because psychiatry is so underserved, there's huge motivation to try to be creative.
So you're talking about going from a 4 and 4 and 1 track to potentially a 3 and 4?
3 and 4. That would be the
including,
most efficient
including fellowship
way,
training.
including child.
I think we have to particularly commend Texas Tech for doing this in a capitated funding model where they have a disincentive for shortening medical education.
Yeah.
And there is also an opportunity there. I think we could get more innovation on shortening medical education if schools weren't penalized for doing so.
Yeah.
Talk to us about your penalty.
Tuition.
Well, you get paid by head per year, so if you eliminate a year, you lose 25% of the funding that would have been derived from that student.
Is your preference then to go to outcomes-based funding, just straight graduates?
Well, that sounds better to me.
It does, and taking the cut for per head that if you allow them to finish a year early.
I like it.
Yeah.
I mean,
Hits a lot of the marks.
I think this board and certainly staff are proponents of outcome-based funding. We're kind of trying a little bit of it at the undergraduate level, but if the medical schools think that would be a good thing, I'm sure that David McGregor, we can work up some kind of a proposal with you and propose that to the legislature.
That year of funding would go a long way to helping fund that first year that residency position that year.
Yes. There's the trade-off.
That would be a huge
Well,
help.
that's exactly my point. Is that now we have money for the first year GME.
Right.
We have also looked at Texas Tech's program, and there's been a lot of interest at TCOM in replicating that track, but getting over that hurdle of a loss of 25% of that student's funding has been a real challenge for us as well. So some creative program that looked at number of graduates versus numbers of butts in seats over the 4 years would probably be helpful.
But you're making up the loss of that year by having actually supervised instruction 2 summers, 2 of the 3 summers.
Right, with the same faculty that are there year-round. I mean, we did not, well, I won't say that completely. We did add 1 FTE faculty in family medicine when we began this program.
I think we need to be careful that while it may be a very good thing to shorten medical education, it doesn't automatically free up 25% of the money, because the costs of medical education are not evenly distributed over the 4 years, and most deans would tell you their 4th year costs them less to produce. So you squeeze it to 3 years, you're not going to have 75% of the cost, but you are going to produce doctors quicker and get them on to residency, and there is room to reduce the cost of education, just not proportionally.
So is 10% a reasonable number?
East.
I don't know.
I think that'd take a little bit of study rather than shooting from the hip.
Yeah.
Yeah, John Hawkins from the Hospital Association. I just wanted to add a few comments. I certainly appreciate what folks said about really the current disincentives in the funding system that kind of drive hospitals to fund residency programs that aren't necessarily what the future medical system needs. And I would just like to point out, though, that the world is changing, and a lot of it is being driven by payment reform. Hospitals are having to deal with bundled payments, accountable care organizations, pay for performance. These are the types of payment models that will basically, force them to look more at how they're funding primary care in their communities. And in fact, most hospitals are part of a larger healthcare system that are providing considerable resources out in the community because that actually meets the needs of the community and improves their outcomes. And once they're paid on that, I think it will certainly provide the right incentives for them to focus more resources in that area. You also have to look at the fact the state is now penalizing us 40% for inappropriate ER utilization. So again, we're looking for ways to move resources into the community for primary care. Readmission penalties, we're going to be penalized for inappropriate readmissions. Again, that will force us to look at community resources as well. So, I think all of those things will help refocus resources within hospitals and healthcare systems, and certainly any money that the state could put into that system, any little incentive there, I think would drive hospitals to put more investment in that. So I certainly appreciate your recommendations in that area. And then finally, I'd just like to add a little more clarity on this, on the waiver and the DSRIP piece, and just to point out that there are some challenges there. Ultimately, that is going to be an issue of financing. Right now, the state is not financing the state's share of that program. The public hospitals and county governments and health science centers in some cases are being looked to finance the state's share to draw down those federal funds. So that will continue to be a challenge, and I think you alluded to that earlier. And the second little technical issue that we're working through is CMS is kind of forcing us to jump through some hoops to make sure they are not providing federal funding for resources that we are already spending money on. Now, we're arguing that under the current upper payment limit UPL program, we're actually using those funds to create physician coverage, even some GME activities in communities. So ostensibly, this waiver was to replace that funding. We still ought to be able to leave those resources in the system, and I think we'll get there. I think Dr. Janik is being very helpful in that. But it's anytime you deal with CMS, it's not a straightforward negotiation, and so hopefully we'll be able to overcome those hurdles, and in some of the second pass funding, we'll be able to flow some more funds into those GME type activities.
Thank you.
Can I ask the group here, when I first read the information about funding for PGY1 positions, my first response was anxiety about what will happen for the subsequent years. So I just wondered if people had conversations at home about that among this group. Fight over the mic.
I can't say about this specific program that we've had conversation, but with our hospital partners and other potential programs, there has been a lot of conversation about what happens at the end of this 3-year grant period, what happens at the end of this 5-year grant. And so if the hospital is at all nervous, and most of them are, about how to continue the program, then it just never happens. Because someone mentioned earlier, I think might have been you, that nobody wants the embarrassment of upscaling a program or starting a new program and then having to close it in 3 years or 5 years when the funding goes away and isn't renewed.
I think one of the things that's important to recognize is that the commitment you make to a program also extends to a commitment you make to the trainees within the program. And when you let's go beyond a 3-year commitment to a 5-year commitment for something like general surgery. In fact, if funding does not follow that resident through the entire training program, and you're put into a position in which you have to squeeze your educational resources for the training, the entire residency program tends to suffer. And that's another it makes people, I think, a little bit hesitant to move forward aggressively when there's not a long-term commitment.
We've had a number of anxious conversations because as you look at this report, we're not going to create 220 PGY1 positions in time. And the problem is at a national level, too. So we're going to have graduates that can't get a job. And that means that maybe we shouldn't try as hard as we've tried in the past to help some of those near the bottom of our class to succeed. And we've tried hard for the purpose of trying to create a diverse workforce, and for all the right reasons. We try to help every student to succeed. But if they're going to graduate and do poorly enough on USMLE and such that they can't get a residency, we would actually have done them a favor to flunk them out in the second year and let them choose another career.
Could there also be an opportunity there to not admit some students that may be on the borderline, or that you may not admit because you don't need to fill the full class size because they're not going to have residency positions, instead of flunking someone out who's then going to have additional debt that they're not going to have a job to pay for?
We recognize that the art and science of selecting people for medical school is not fully developed, and we're in the process of implementing a radical restructuring of how we interview people. It's called the multiple mini interview, where a whole bunch of different folks watch the student in brief encounters, and this has been thoroughly studied by one medical school up in Canada. The results are very impressive. It's a much better approach to identify those people who are going to do well when evaluating the softer side. The ability to do well on a standardized exam is easy to measure, but that's necessary but not sufficient to become a good physician. So we certainly agree with you. We can do a better job at selection, but we don't think we've been doing a terrible job.
No, I was just concerned about
the applicant
giving up on students. That's the way it sounded, was that we had been working to really try and help them through, and since we weren't going to have enough position for them, we'd stop helping them through, and that concerns me.
Let me change the word from giving up. This is a personal opinion. This is not an organizational policy statement. I think maybe sometimes we've tried too hard. And I think other schools are guilty of the same if they'd be honest about it, because you get an emotional investment in a student and you don't want to see them fail. But no matter how good admission systems are, they're never going to be perfect. And you get some students that probably shouldn't be physicians, and I think we've tried too hard on some in the past. But the question was, have we had discussions? And the answer is we've had discussions, and they have concluded that maybe some of these students would be better served by being excused earlier rather than not being able to get a residency.
What is the graduation rate?
99%.
Yeah. Right. It's very high. And that I would like to add to that, too, that the applicant pool continues to grow and continues to increase in competitiveness. And so the fact that we might not should fill our classes because there aren't enough good students to fill them with really is not true. We have an abundance of students that can become excellent physicians. I think there are some external pressures that we all deal with as far as trying to meet the needs of an increasingly diverse population and increasing the diversity in our workforce, and how we go about that, and definitely lots of attention on the multiple mini interview as far as being able to more accurately predict who's going to do well from a social standpoint, especially in medicine. There's a lot of exciting things on the horizon to help us do a better job of that, but it's not a lack of qualified folks at all.
Man, it seems to me that there is a significant level of concern about being able to provide residency programs for our existing graduates, for the students that are in our current medical schools getting ready to graduate. Does anybody have any thoughts about the discussions that have taken place with regard to adding additional medical schools and additional programs, and what that will do to the current crisis?
I think it's entirely unfair to the students to bring them into medical education knowing that there's not spots.
Well, I'll tackle the UT Austin Medical School since it's the one that's looming out there, and Ed to the north can talk about Texas A&M. But one of the things that is happening right now in Austin, as I've mentioned earlier, is we are increasing our GME capacity to anticipate an entering class of medical students some years down the road, not yet decided when. Think about getting through the LCME accreditation. It could be 5 years before we have a class. It could be 8 years if they go through an accelerated program, or 9 before they graduate. And by then, we will have added over 100 residency positions to the Austin community.
And I guess but that doesn't even address the statewide issue, though.
No, that's just
adding 100 residents doesn't even get us close to the 1.1 to 1, which we're looking for.
In Austin, where are those additional slots being added?
All with the Seton Healthcare family right now. We go to the federally qualified clinics, community care, Central Health have all been involved.
And that's 100 over 4 years, so that's 20 slots a year?
No, it'll be 100 total positions, but you figure it's going to be around 40 to 50 entering positions by the time we wrap up all the programs.
Okay.
We still have about 6 of the core programs that we haven't even started applications on.
And I have concerns about that, but I would elaborate upon them if the contemplated school were not so geographically close and if I weren't sitting next to Sue. Because honestly, should it come into being, it will be my goal to develop the strongest possible collaborative relationship with that school, and I don't want to say anything today that would be detrimental to that collaborative relationship in the future. I trained in a city with 2 other medical schools, and my medical education was much better because of it. So I'm going to kind of pass on this one.
And my concern is more on the residency side than on the facility and the medical program side. I'm just trying to see, okay, if we know we're already at a deficit, what is adding, 200 more graduates a year going to do in terms of what we're able to accomplish? Because I'm actually, based upon this conversation, I'm now more concerned about the ability to expand residency programs than I was even when we were putting the report together. And so that pushes it back in terms of adding more graduating slots and what that does for the need to maintain that 1.1 to 1, even though we all, you all seem to indicate that 1.1 to 1 is actually the bare minimum of what we should have. And we're not even close to that yet without adding more medical seats. So, okay, well, thank you very much. I understand the questions there.
Well, I have a question. So are we being too conservative, and is our guesstimate based on the graduation rate now versus, I know some of the schools have already bumped up their enrollment. Are we looking at the bumped up enrollment and we've taken that in? So how would you address their concern about the first year residency, that's all we're really funding?
In Texas, we have a big challenge, as everybody here knows, that we fund on a 2-year cycle, and that one legislature cannot impose requirements for funding on the next that are guaranteed to happen. And we've frequently seen programs that are funded one biennium with riders that say, and it is the intent of this legislature that these be continued for 10 years, that lose their funding in the next biennium. And so that's certainly a challenge, and it's certainly one that from a legislative perspective, we would need to try and develop the strongest support we can in the legislature to ensure that continuation.
So you're saying really every GME spot right now is funded like that? Just
absolutely.
Every 2 years.
And
that's all you
we
get.
felt the pain of that over the last 2 biennia.
So really this isn't just, okay, we're saying 500 spots. If we got funding for 500 new spots, that's really not going to make it any different than the spots we've already got.
In terms of the assurance,
right.
No.
So there's no
guarantee,
written in blood guarantee. Okay. My other question is, have any of you already talked to legislators? Have you picked a champion? Do you know who might lead us through the session? Does anybody have a plan?
And I'm afraid I'll have to defer to our external relations folks and Linda Battles, maybe, in terms of having a plan and champions for the GME and the PELRP. Have we talked with legislators about that yet, or not at this time?
If I could address that, the Texas Academy of Family Physicians has put forward a draft proposal for the primary care solution for Texas, and has approached several legislators about that, and contained within that is the fact that we're excited about your proposal to restore funding for family medicine residencies and to have a competitive loan repayment program. So we're very thankful for all of that. But we have been looking for collaborators to help support this initiative. I did want to pick up on what you had said before about your interest in outcomes-based medical education, that item 3 of our 11 recommendations is that we tie the outcome of graduation from medical school into a primary care specialty as something that gets stipulated, so that there's some put your money where your mouth is. So I just wanted to say.
Just briefly, there was a hearing in Houston with Representative Colcourt's committee. And at that meeting, at least the sentiment I got from the state reps there was that they thought 1.1 to 1 was beginning, but it was not enough. And so there was some sentiment, at least with that committee, and they wondered why the board had not recommended more. And I essentially said what McGregor said earlier, was that the board was operating within the sense of the current economy, and that was what the board thought was a reasonable request at that time. But I didn't think at least would oppose a larger number if that were to come forward.
Just to quickly follow up on what Dr. Hawkins said, I'm Tom Banning. I'm the CEO of the Texas Academy of Family Physicians. I'm happy to share, and I may have already sent to Stacy and Elizabeth a set of recommendations that the Academy's putting forward. We're publishing the next quarter of our magazine that lays out in fairly stark terms, what y'all are up against, what we're up against. And about a year and a half ago, we retained Dr. Charles Bell, who was the number 2 over at HHSC under Commissioner Cease, to develop a set of recommendations to begin to move us forward to address the impending or occurring crisis that's upon us on workforce. In terms of legislators, we have reached out to about every member of the Senate, and a significant number of House members. I think that a few members of the Senate may have already contacted the coordinating board to run ideas past them. So I think that there is a lot of momentum going forward, and I think that the legislature would be well served and well helped from some good direction from the coordinating board, which it sounds like y'all are on a right path forward on.
Thanks.
Since the last legislative session, President Dickey and Jenny Jones, myself, and others have met with numerous legislators to educate them about this impending GME crisis. And as far as specifics go, Jenny has coordinated all of this and could cite specifics, but we've been working to educate them, basically.
Marcia Collins, Texas Medical Association. I'm a policy person, actually don't cover legislative affairs, and I apologize I didn't introduce myself the last time. I wanted to let you know that we have a single document that we will be looking to potentially update. It is a medical education consensus statement. This would be our 3rd time of producing this. We have a meeting that's scheduled next week with our Council on Medical Education, and we will have many of our representatives from the medical schools there, and we'll be talking with them about the potential of updating that. It's a single document. In the past, we've had all of our medical schools as well as our teaching hospitals to sign on to the document, so that we were identifying the priority concerns for, and it was an educational document for the legislative session. So again, it would be the 3rd time that we would be updating that. It contains basic information about where we are in terms of workforce trends, so that we're able to educate the legislators about the latest trends and our needs for the future. But then also talks about the individual legislative, I want to use the right words here, issues that we all agree upon that the legislature should focus on during the session in order to impact the workforce needs.
Thank you.
And when do you think that document would be available for our review of it?
We will have that in time for the legislative session is the plan. We're starting a little bit earlier this time. We hope to have a very good draft by November.
Yes, ma'am.
One of the areas that my office works with is the J1 visa waiver program, which allows Texas to recommend 30 waivers for J1 visa physicians in residency to remain in Texas and practice. That's far below the number of J1s that are actually coming out of their residency training. So we're only able to keep 30 out of the number that finish their training. in the past, sort of the historical perspective has been that 25% of residents are international medical graduates, and this was sort of the gap between the number of medical school seats and the number of residency slots. So as we've increased medical school seats, that gap should be closing. So I'm kind of interested in seeing how the IMG opportunities would be impacted by this. I think we absolutely want the opportunity to keep every resident that we train. And if we're not able to keep them because of the cap on the number of J1 waivers, we're better off having, a U.S. medical graduate that doesn't have to leave the state in order to remain in the U.S. So I'm kind of interested. Before I started working with numbers and statistics at the health department, I never thought 25% was very much. Now I'm pretty keenly aware that 25% is a lot when you're looking at graduates and the potential for keeping them in practice.
Any other subjects, topics? While we're all together, I can assure you this has been very, very valuable from a coordinating board standpoint. We greatly appreciate the insights and the input, and I know that staff will take that, and I know that my colleagues found it to be very, very interesting and very, very informative and helpful. Any other questions from staff or the committee?
I think the only question I had is, did we adequately answer your question about the funding for the first-year GME and the concerns about going forward on that?
That it's similar to the 2-year anxiety.
Right.
Yes.
So
I think my concern is I don't want a program to be created and then us not use it. That would be the worst outcome. And so I was just trying to figure out from this group if everyone was going to figure out a way within their places to make that work. And I think we will, but it's a difficult position to be in, and I want it to succeed if we spend the money on it.
Well, we would agree, and I think the thing we don't want to do is disenfranchise students that are in the middle of their graduate medical education by defunding programs that we just created. So I think the point is yeah, we may be in this biennium creating 220 new spots, but the price is going to go up in the next biennium because now you're going to have a cohort of 3 years of folks, so you're going to have 660 slots if you play that out on a 3-year average. So I think when we talk to the legislature, we need to say, yeah, this is the price this biennium, but this is the price the next biennium. And if you really want to do above and beyond that 1.1 to 1, you're going to have to get a couple zeros. Or buy a vowel.
I guess I'm hearing it's an impossibility because of how the legislature rules are set up, that the fact that it's 2 years and training is 4 years, it just doesn't matter.
It would be a unique situation if the legislature funded it and said, here's 5 years worth of funding with, you can encumber it for the 5-year period. And so that would be, I would wager, a unique situation. So I don't have a lot of hope that would happen.
But they're aware of that being a concern and a problem in trying to figure out, understanding the situation and what the predicament it puts everyone in.
What is the timeline on the match program? When do the students have to have their match requests in?
February.
Say again?
February, they turn in their rank list, and we notified in mid-March.
And the program's January 31st is the date that you can change the number that you would like to match for. So that's really a critical date for the from our end of things, and then we put in our list, and the students put their list in February.
So I'm assuming, and I'll throw this idea out loud, how do we get some of those GME experiences to begin in 2013? It would require that the governor would have to call this an emergency issue, and it would have to pass both houses and be signed before January 31. Is what you're kind of telling me, right? For then the programs to say we're offering 6 spots instead of 4 spots.
Right. And that would assume that the programs have approved slots that they're not filling. If we need to submit applications for approval of additional slots, we have to know well before January.
Now, I thought that within your approval from ACGME, there was a certain flexibility where you go add additional slots without approval. Is that not a fact?
I'm reaching back a little bit here from my program director days. If we had a resident that was off cycle who had taken a maternity leave or something like that, had been out for medical illness, whatever, if that caused us to go a few slots over what we were officially approved for, that wasn't a big problem. But we couldn't just add 2 slots per class or 4 slots per class because we had an opportunity.
So there are kind of 2 categories of increase in resident complement, one being a temporary to address these sorts of issues where you're off cycle by 3 months, 1 month, a year. Then there is a permanent increase in resident complement, and those actually have to be processed, and they're processed in a rather detailed fashion by each of the individual residency review committees to ensure that the educational resources, in addition to the funding, are available for training. So that can sometimes take a review cycle period of time, so up to 6 months to a year.
Okay, so that's the other timeline. So it is approved, it's signed by the governor in June. By the time we get back to January 31st again, are we going to have enough time to process that so this can be actuated within that biennium? Because really what we're talking about is first year slots, July of 14, which means
there would be time.
That would be time?
Yes. And people could get ready by January 31st for that year.
It would probably be a good idea, though, to start informing programs that this is on the horizon so that they can be prepared at the moment that that funding became available, that they could start moving forward with their applications to ACGME.
So
gather all the data ahead of time.
Right. Can we count on you to inform your programs?
Absolutely.
All right.
It seems at times we're so caught up with solving the crisis of the moment that there isn't time to think about a real fix. Now, at the risk of revealing my ignorance of state government, the 2-year thing is going to be a big problem if we're talking about enough money that matters. The only reason that 2 years at a time hasn't been an issue is there's been so little state funding. It didn't matter that much. Is it impossible for the legislature to create a state-based all-payer system where the money comes from the insurance industry? They have to be licensed by TDI to sell insurance in this state.
Well, that's what we were talking about with our 5th recommendation of the all of the above. So if you've got a model of how that might work, we're certainly interested in testing those models or having other agencies in the state test those models and provide advice to the legislature of how it could be funded in an alternative, i.e. not CMS, not the state of Texas, alternative format.
Is there another state doing that?
Not that I'm aware of. I'm not smart enough to come up with that model by myself, but I'll talk with Jenny and a few other folks and see what we can do.
I think it's called the OPM model, other people's money.
Love that model. Anything else? Once again, thank you very much for the input and your time. We appreciate it, and we stand adjourned.